Hello and welcome again. In this video, we're going to discuss about TMJ and full mouth reconstruction. When to say no to full mouth reconstruction or when to hold off for full mouth reconstruction related to TMJ. So whenever I'm doing examination, I am looking at load testing. As we discussed in our previous video, you could use Lucia jig or you can use leaf gauge. Leaf gauge is usually very quick, and that's why usually leaf gauge is my preferred method where I'm doing load testing. Whenever you're doing load testing, what you are assessing is that when you are making patient into relaxed position, into CR, and when you're asking patient to close, whether patient feels pain or not. Usually, ideally, when patients are in CR, they should not feel any pain, because when they're in CR, your TMJ is in the right position, and if patient feels pain, then that suggests either intracapsular problem or sometimes spasm in lateral pterygoid muscles. The spasm in the lateral pterygoid muscle can be broken by putting two cotton wool rolls on the posterior teeth simultaneously. Ask patient to squeeze and release, and that can release that spasm. However, many times if there is a load test and there is a pain, then that could be intracapsular pain, and that's what needs to be looked at before you do any full mouth reconstruction, because it's a high risk patient where there is a chance that if you've done full mouth reconstruction, then patient can develop TMJ symptoms. If patient comes to me with a previous history of pain in that TMJ, this is not a completely absolute contraindication. However, I will be very aware of it, and I will make sure that I will do mock-up, which is reversible. So I will never do provisional crown straight away. I'll just add something to the teeth, or even give patient Michigan splint and test out my occlusion before I do the reconstruction for that patient. Because it's very important, when patient has pain with that TMJ, it shows that patient's adaptive capability may not be good enough, and because of that you need to be very careful when you're increasing or decreasing that OVD. If patient cannot tolerate Michigan splint, so many times if patient comes to me and if they are really stiff muscles and I'm struggling to deprogram their mouth, then I prefer to give them Michigan splint before I do any full mouth reconstruction. And if I'm giving Michigan splint to those patients and patients not being able to tolerate the new occlusion, that suggests that the patient's adaptive capability is not as good as I need to be in order to do full mouth reconstruction. And because of that, you need to be very wary. Until and unless you get rid of that pain, you need to make sure that you don't proceed with the full mouth reconstruction. So the alternatives could be that you reduce the thickness of the splint, or you try and give patient a splint in CO, which is very difficult because you need to create a hole in the splint so that the first point of contact is maintained. Because many times study shows that the patients, if you restore patient in CO, you're not really testing that adaptive capability, and patient is very well within that range of capability, and patient usually adapts in, and that's why many dentists prefer to do full mouth reconstruction in only CO, and they don't restore patient in CR. And you need to also assess that when patient comes to you with the pain around this area, you need to be able to assess whether patient's pain is related to TMJ or masticatory muscles. And if patient's pain is related to the muscles, then you need to do the appropriate treatment to relax the muscles, give them Michigan splint, relax those muscles. But if it's intracapsular pain, then you may need to refer patients to specialist oral maxillofacial surgeon in order to see if anything possible. Most of the time I end up giving patient Michigan splint anyway to start with, even if I feel that there is intracapsular pain, and then see whether that splint is helping them or not, because otherwise other treatment are very invasive, and before you go towards invasive treatment, you want to do something which is non-invasive. So I hope this video was useful. If you have any questions, please feel free to contact me. In the next video, next 2 videos, we are going to discuss about how you're going to differentiate between intracapsular and muscular pain.